My name is Karen Carlucci, Standards Training and Practices Manager with the Lifeline based here in New York City. We're very happy to see a good number of you already have logged on. It's the second webinar this month. We aim to deliver a webinar each month, so always stay tuned for what's coming on the calendar in the Lifeline weekly announcements as well as email alerts. Again, my name is Karen. I am introducing this webinar. As many of you know, I coordinate and facilitate, and I've worked with many of you, so thank you for being part of this process and delivering information to the community. We have one center speaker that we are featuring today, Becky Stoll from Centerstone, who we will more thoroughly introduce. Remember that you should mute your lines if you have not already. If you've been via the conference line, go ahead and mute your phones. You can chat in at any time with a question or comment, and one of us will get back to you via the chat. You also want to mute your computer speakers to avoid any feedback. But as many of you are aware, if you are not speaking at any time during this particular webinar, you can often hear the sound via your computer if you prefer that. A reminder, as we always mention, do not place the conference line on hold at any time during this presentation. That disrupts the sound for everybody. So you can always hang up and dial back in if necessary. Thank you to that. So again, this is our second May Lifeline webinar, Zero Suicide Framework in Crisis Call Centers, Beginning the Journey, where we will hear from Becky Stoll, Vice President, Crisis and Disaster Management at Centerstone, one of our Lifeline Network centers in Tennessee. And we will first hear from Shari Sinwelski, Lifeline's Associate Project Director, just to provide a little bit more of an introduction and more fully introduce Becky. I am going to, at this time, go ahead and remove this poll question for those of you who went ahead and answered that. Or actually, I'll leave it on another minute if that's okay. I'm just covering up a photo, but I will remove it in a little bit. But while you're having a chance to still go ahead and complete that, I'm going to introduce Shari. Shari?
Give a little bit of history as to sort of why we're focusing on this webinar today, and then I'll take a moment to introduce Becky. The Lifeline received a supplemental grant. It's not uncommon for us to receive supplemental grants to do special projects for the Lifeline and for our centers. And the supplemental grant that we received for this fiscal year, one of the projects that we're focusing on is the Zero Suicide Initiative. Many of you are maybe are not aware of the initiative, but it's a project that's been spearheaded primarily by the SPRC and the National Action Alliance. And Becky's really going to tell you a lot more about what the Zero Suicide movement is. But Dr. John Draper, our Lifeline Project Director, has also been very involved in the Zero Suicide movement. And through his work with Becky and others that are part of the movement, we really just started asking ourselves, you know, how can crisis centers, what do crisis centers need to know about zero suicide, and how might they become more involved to use this initiative as a way to really champion and highlight the services that they provide in local communities. So the project that we're going to be doing over the course of this federal fiscal year includes some education, which is one of the things we're doing right now, this webinar, to just help people to become more aware of zero suicide and what the movement is. We're also going to be creating some tools, some online tools for centers to see how they may be able to help their organization become more zero suicide ready, and you'll learn a little bit more about what that means from Becky. And then lastly, also, how might the Zero Suicide movement present opportunities for crisis centers to form better collaborations with health and behavioral health care organizations in their local area? So that's really the focus of the project. I'll talk a little bit more about some specifics when we close this up at the end. But before I say any more about what we're doing, I'd just like to take a moment to give you all a little bit more information about Becky, who's going to be our guest speaker today. Becky Stoll is responsible for the overall operation of Centerstone's Crisis and Disaster Management Services. She's a licensed clinical social worker with 20 years of behavioral health experience. She's a recognized leader in the area of crisis services, disaster mental health, and suicide prevention, and she's a member of the National Action Alliance's Zero Suicides in Healthcare Advisory Group, as well as serving as a faculty and mentor. She has provided training, consultation, and response nationally and internationally to aviation, banking, educational institutions, emergency response organizations, and professional sports organizations. So without any more information or further ado about Becky, I'm turning it over to her to get us started on the webinar.
Great, thanks Sherry. So I can see we've got, I think, about 41 of us online, so just thrilled that you all could be here. Hope that you're in a part of the country that's not seeing a lot of flooding or tornadoes, and hope everybody is in good, safe places. Just seeing a lot of that in the media. So we're going to spend the next probably 50 minutes or so, have a lot of information. If you have questions, feel free to type those in, but I'm going to go at a pretty steady pace because we just had a lot we wanted to get to you, and you can come back and ask questions or get consultation later. So Karen, if you want to go to the next slide. So if anyone likes to tweet and wants to tweet out during this, I know there's a lot of activity that spurs around the Zero Suicide. This is the tweet handle. If you want to take a selfie of yourself and tweet that out. So next slide, please, Karen. So the Suicide Prevention Resource Center is on point via the National Action Alliance around the Zero Suicide in Healthcare and Behavioral Healthcare Initiative. And they are really leading a lot of this initiative, kind of serving as a hub and a portal around a lot of this work. So the National Action Alliance, I know you all are all probably very familiar with their work and their initiative to advance the national strategy around suicides and to try to decrease 20,000 lives in the next 5 years. So via the Action Alliance, funding goes to the Suicide Prevention Resource Center, and we'll talk a little bit about what the Zero Suicide movement looks like. So what is it? A lot of times, when I get asked to speak or I'm out on the road speaking about this, most people nod their heads and can buy into the notion that, having no one in our care in health or behavioral health take their lives sounds like a pretty good idea. Occasionally you get, the question, the pushback a little bit of, gosh, that's an awful audacious goal. And I think we all nod our heads back and say, you're right, it is. But that's what it is. It's a goal within organizations and systems to always shoot for this, knowing, I say here at our agency, every day and every month we go by and we don't have anyone take their lives in our care has been a success. In health and behavioral health, can you sustain that? Probably not. But it surely has to be your bullseye that you're looking at. And I think if you create a culture with, not blaming folks and being very collaborative in nature, it's the right way to go and the right phrasing of where you want to try to get it. So Zero Suicide is embedded in the national strategy, and it's a project that's really focusing, and I love this, it's error reduction and safety. And that really is a failure on a healthcare and a behavioral healthcare system if we have a suicide in those worlds. So we want to become much more systematic and comprehensive, and I love David Covington's words, and I steal them, but I like to credit him with that, is really you have to look at trying to bake these components into your system and not really bolt it on. And so you need the tools and the infrastructure to do that, and I feel like that's, at least for us, and I think for others, gives you that framework to make that happen, and that suicide prevention is not just a niche program or service line that we kind of have over off to the side, and if someone's trying to speak with a clinician about that or a crisis counselor about that, that we're not kind of shoving them down the line. So how is it different? It's different in the sense that it's a core responsibility, and that thread runs all through the system that you're in. So if you're a crisis center, and that's what you are in totality, that it runs through the organization at all levels. If you're comprehensive and you're large, which makes it tougher, obviously, you still see that thread, that it runs through the fabric of everything that you're doing. And that it's everybody's job within the organization to try to prevent these, and that it's not just a few isolated personnel within your system that are trying to move the needle and get suicide reduced or eliminated in your program. And these system-wide approaches have really worked. The two examples here are the Air Force Suicide Prevention Program, and then you can read about the UK's program from 2009. So I'll tell you, having done all this, a shift in perspective really has to occur within an organization for this to happen. And you see these here. I'm not going to read them all, but I can tell you accepting that suicide is not inevitable just because of the populations we're working with is huge. And that'll be a real culture shift for the majority of your staff. And taking up the notion that every suicide is preventable up until the last, moments is a shift, a lot of staff really can buy into, though you do have some naysayers, a lot of our staff that maybe had been around a little bit longer, saying if they want to do it, there's nothing we can do. So all of these that are listed here, this kind of assigning blame versus, looking at a completed suicide and trying to learn from it, all these things listed here very much are part of what it takes to shift a culture. And we have found it really takes years. Unless you're just a very tiny agency, then it might take a year or more. But I think in significant size agencies, this is years worth of work to try to get people to get to the point where zero's the target, and we're all kind of rowing in the boat the same way. So there's kind of some pillars, which was really a nice framework. I know when we started this work and seeing it even flesh out more, it's looking at how do you do this and this kind of continuous quality improvement approach. And you see some of those listed here. So you want to have a leadership-driven, safety-oriented culture, and that's really almost where you have to start. And then you move down to having a workforce that's ready to handle this kind of work. Those to me were, the things that we had to do in the beginning, and I'll talk about that in a moment. And then you kind of put in the care management of a patient or a client and how you're actually going to deal with them. And if you have electronic records in place, those are very, very helpful. But you have to start with having a culture and leadership and a workforce that's ready to implement whatever care management plan you develop. So leadership's commitment, that's really where you have to start. If you don't get the top senior level of your entity to buy into this, I think you're going to be really swimming hard upstream, and I don't know that you get there. So you try to be purposeful about making public proclamations about leadership commitment, and really starting to look at the safety component, and that we're going to do things and put structure in place, which our staff really wanted, and I think most clinicians across the country would want, is to have some kind of expertise in their toolbox where they can treat folks and not feel like they're, having a hard time treating them. And then if you actually have a completed suicide, that you're not going to get blamed for that. And that we're going to have a system where we, all are looking at the same things and trying to move forward. I think it really freed our staff up to try to embrace doing some of this work. You want to have something where you can assess and screen. So there's plenty of tools out there. You have to pick one, but we need to screen folks and subsequently assess those that, screen positive to see who we might have in the system that has elevated risk. Again, you have to have assessment, and what tool are you going to use to do that to get people moved into some kind of pathway to care if you ID them as high risk for suicide. Safety planning, means restriction, other huge components so that people that are at high risk have one and they have it in their possession. And then really being aggressive about restricting means. And I'll talk to you in a bit about how we did that. Henry Ford did a lot with that, but how you're going to communicate with family and friends and get confirmation and things like that. But you want things in place. This one here is a huge pillar of having a zero suicide framework within your system. Employee assessment and training, it's one of the first things that probably need to be done if you're going to play in the zero suicide sandbox, because the suspicion is that probably employees are not ready to handle folks that are suicidal. I know when we talk to lots of different people across the country, lots of us did not get that in our graduate programs. We don't have the training, we don't have the skills, we don't have the support. And so when someone is suicidal, we call people in crisis services to come down and try to deal with that situation because they just don't feel equipped to do it, and they're afraid of that. So doing a workforce readiness survey is a wonderful place to begin, and then putting together some kind of training program. There's plenty of training right now on great topics that are at no cost. And trying to get the staff feeling a little bit more like they have some skills and doing things that provide them support so they feel like they're ready to take on this mission that we're asking them to take on. And then having some kind of a management plan in place. We call ours a suicide pathway, and that's what I'm going to talk about in a few moments. But you have to develop components that say, we're going to have this great culture, we have our leadership buy-in, we've trained our staff, we've screened, we've assessed, and where you end up is with this pool of people that you've ID'd as being high risk for suicide, and then you have to have some kind of care management plan in place that says, here's how we're going to treat them, here's how often we're going to see them, here's how we're going to follow up with them when they don't show up. Here's the evidence-based treatment modalities that we're going to use, and here's how we're going to engage them. And this is a very large piece of the pie that has to get baked because, to be honest, IDing folks at high risk for suicide has in some ways been the easiest part. It's more once you ID the pool of people, what do you do now? And how do you keep up with them once you have put them, so to speak, on the grid? How do you do that? And someone asks, such as ASSIST. Yeah, ASSIST is definitely a training program that a lot of agencies use, and I think you have to look at the different training programs out there, and there's a pretty comprehensive list I think the SPRC has put out that kind of tells you what the training is and who might benefit from that. Because you have to decide, do you want to train everybody from your front desk receptionist type folks all the way through clinicians. And I can tell you a lot of people are looking at doing that and not just training clinical staff. I think the hardest piece in this pillar of treatment that you're trying to put into place for folks is using effective and evidence-based treatment. There just aren't that many So to look and say we have a plethora of options and just come and pick one of these great entrees we have, it really, as you guys all know, I'm not telling you anything I think you don't know, is there's not tons of evidence-based treatment around suicidality. So, looking and seeing what is out there, whether, it's looking at CAMS or looking at DBT or CBT, and then really figuring out how you're going to introduce those into your system and be consistent where they're actually being used and people have the support they need to bounce that off of someone and get supervision. I have found this one to be the hardest, again, because I think we don't have that many options. I just think it's one of the tougher ones. Follow-up engagement, this is where crisis centers rock and roll. It's what we're good at oftentimes. So developing some kind of system where you're keeping up and keeping all these people on the radar and reaching out to them, whether you're doing that between visits, doing that when they don't show up for visits, but keeping, good contact with people and keeping them monitored at all times. I think besides evidence-based treatment, to me the second hardest aspect has been engagement. A lot of times, folks that get identified as high risk for suicide, it's very hard to get them engaged. And you often find you have to look at what are some of the alternatives we have to engage them. And I think call centers play a huge role in that. But if we can't get people to come in for in-person meetings and treatment, or we can't get them to, be home when we send folks out to their house, like in case management type services, we have found it's been hard at times to get people engaged, and looking at alternate ways to engage them while being cognizant of, mental health is not rolling in dough. So it's often hard financially. Sometimes it's not want for ideas about how to engage folks, but is it a billable service? And, we all need to have services that we can bill for and make money and keep our lights on. So sometimes it's difficult, and you know what you need to do, but finding the funding for it or being able to bill for it is difficult. Quality improvement is an enormous piece of this, and I really encourage folks, if you don't have a system in place, that you're keeping data and that you know how many people in your care have completed suicide in any given month. How many suicide attempts have you had in any given month? And if you can even go and be able to slice and dice that, where did they live? Were they male, female? What race were they? What age were they? What meds were they on? If you have that kind of data. If you don't have that kind of data, just whatever data you have, being able to kind of look at that so you can try to target some of the initiatives that you want to roll out within this. Reports become very important so that you can keep up with people and that you are having good fidelity. That's a huge piece. It's one thing to build these kind of infrastructures and say we're going to do all of these things, but having reports to bump up against and say, are we really doing this around means restriction? I mean, we say we are, we have a policy on it, but constant looking at the QI aspect is something that it will require, and I really think help move you up the field as you try to get this more in place. Evaluation becomes, I think, a little bit more difficult because there's often just no funding associated with it. I know whenever we write a grant, we try to make sure we put some kind of an evaluation component in it, and we've been able to do that with some follow-up. But other aspects, it becomes hard. So if you do have any success in the zero suicide field, you're not quite sure what pieces helped. Is it A, B, and C, or was it just A and C and you really could not do B? It's not helping. But the evaluation piece is a little bit tougher. So anytime you can write it in or get funding for that is a good thing. So on the SPRC website at zerosuicide.com, there's lots of tools and resources that, a lot of different agencies from across the country, some being providers, some being state departments of mental health, is just sharing that and kind of having that stuff as a repository. Things like workforce readiness surveys, organizational readiness surveys, different kind of policies and procedures on certain things. You can go to that website and get some really good information. And there, as you guys see, is Mike Hogan. And there's a few short videos. But at the bottom of the website, you'll get, if you click on lead, train, identify, engage, treat, transition, or improve, that's whatever these are kind of the pillars of the Zero Suicide Framework. And if you click on any of these, you get some information to help you build that out in your own organization. So that's the down and dirty on just the overview of what the Zero Suicide Sandbox kind of looks like. So I'll tell you the journey that Centerstone took to kind of play in that arena. So we got started, I would say, technically probably about 21 months ago. Centerstone, it started out, we were building clinical pathways for a lot of different things, depression, anxiety, substance abuse, and the voice in the room, someone said we really should have one for suicide because it kind of trumps all the rest of them anyway. So we started looking at that. Centerstone has presence. We do, all kinds of services on an outpatient basis in Tennessee, Indiana, Illinois, Kentucky, and Florida. So we're a large system. We started in Tennessee, and I would say, Indiana's several months behind us, and Illinois is several months behind them, and Florida is just coming on. So a lot of what I'm talking about today with us will be where we're kind of, we feel, on about the 50-yard line, which is in Tennessee. So in August 2011, I was, just because of crisis in my title, and nobody within the enterprise at that time had, the crisis experience, this was kind of the challenge posed to us, was develop this clinical pathway across all of our enterprise. So at the time, it seemed fairly simplistic, and I didn't quite realize how difficult it was going to be. So we looked at great documents like the Suicide Care and Systems Framework, which is a great document, but I think it gives you the 30,000-foot view as a provider. For other folks, it may give them a lower view, but as a provider, it was really very high level in saying it's great to have this kind of system in place and this system in place. We looked at Henry Ford. They had a lot of success, as you guys know. And we said we need to screen, assess, treat, monitor, and evaluate. We're going to completely overhaul how we're operating. And so we needed the 1,000-foot view. And so as a provider kind of joining a call that was occurring at the time with a lot of state departments of mental health and a payer, which was Magellan of Arizona, we would say, yes, that's great, but does anybody have anything on means restriction? And nobody kind of had that. Does anybody have anything on? And it really just, in a lot of ways, wasn't there. And we needed the view as a provider to come down much lower and actually kind of have the rubber meet the road to put things in place. So we have a research institute, and this project ran through our Center for Clinical Excellence. So we developed a multi-state suicide prevention committee, a couple people from each state. And at the time, I didn't want to do this. It kind of gave me hives because our, person on point who's wicked smart at the research institute said you need to do a charter and you need to write a project plan, and we need planning worksheets that you're turning. And I was like, oh, that just sounded like a lot of paperwork. But I can tell you in hindsight, 21 months later when we really started working on this, putting it in a charter and putting a project plan together was really very helpful for us. And I'm glad. I think some of this stuff may be on the SPR website. If it's not, I'm glad to share it. And then we got executive leadership buy-in. We did, communication out around that. And then we decided to pilot at 4 sites in Tennessee We did that we were going to do it for 4 months. I think we only did it for 3 because we kind of gathered all the intelligence that we felt like we needed. So we're not all the same, and all of you guys on the phone aren't the same. So some of you all, are going to be organizations where it's a standalone center. You're not attached to other service lines, and you might use volunteers solely, or have some smattering of paid staff. Or there's larger organizations where the crisis center is just a piece or a service line within, and there's a lot of paid staff. I think regardless, these kind of pillars work, and it really doesn't matter what size you are. To be honest, sometimes I wish we were small. I think it would be not quite so complicated and cumbersome, and the fidelity would be much easier. But I think regardless of size, the framework works really nice. So here is our clinical pathway and kind of how we got started. So we needed leadership commitment, and we knew that. We got it fairly easily, and we did communication internally and externally. And that started out with the CEO of our parent company, and then it went to the CEOs of each state. And it was kind of this formal proclamation that we were going to change the way we do business. And we were going to make sure everybody felt comfortable dealing with our most highest and most fragile patients. At the next level, I encourage you to have one person kind of on point for the communication. So we have an intranet, and when people see, like, say, my headshot next to those, they know that's probably a communication coming out about the Zero Suicide Initiative. So that kind of cascading from high level to someone who can be on point for it is a good thing. With this kind of proclamation of what does it mean to say we're adopting this, and wording it so that people don't go, gosh, we're never going to get to zero and stay there, but explaining really what the Zero Suicide philosophy is. We did the organizational survey, which was very helpful to kind of give us a barometer about where we were in all these different areas. But the bigger one, I think, that gave us a lot of intelligence was the workforce survey. And we had, at the time, we were trying to poll 2,000 employees, and we got 1,700. And we only had about 43, I think, percent of our staff overall saying like they felt like they had the skills, training, and support to do this kind of work. And that's about what we expected, but it made me very sad that we have so many employees and less than half felt ready to do that. But it really created an opportunity to put a communication out and kind of own that, and that's what we did. We owned it, and we said, this is the survey results, and kind of shame on us for not paying attention to this and making you feel skilled and supervised and trained, and we're going to fix that, and then really living up to that and doing that. So the current components of our pathway kind of look like this in its most simplistic. We have yearly training that we talk about, and I'll get into that in a minute. We modified our electronic health record, which currently is a homegrown record, so we've kind of been able to modify it as we want, but we're about to switch to a new product. Being able to screen, assess, address means, right, crisis, we call safety plans crisis management plans. Some guidelines around frequency of contact, and then ways that we monitor these folks and that we do QI. So our training, the first year we mandated that all staff had to have the Columbia and the SPRC's counseling on access to lethal means training. It just worked for us the first year because the staff had to take the Columbia training to do it. And we really liked the CALM training, and they were at a really good price point because they were free. And they were online, and we could give staff, a good amount of time to be able to get on and do that. Year 2, we use Relias as a training product, and there's a good bit of suicide training modules in there, so we just picked one. It didn't cost us anything because we already had the product in hand, and we picked one, I think, just on suicide screening and assessment. And then it was very obvious to us the second year of our training program that because we are large, that sometimes staff weren't quite clear what the actual things were we wanted them to do. So we created an internal PowerPoint presentation that just says, here is what our clinical pathway is, and here's what the expectations of you as an employee are. And all staff had to take that. And I really wish we had done that in the beginning, but you live and you learn. But that was very helpful to get everybody on the same page so that they weren't asking some of the same questions over and over. And this will be year 3 for us, and we're really just under development about what we're gonna do this year. One thing we did start 2 months ago that I wish we had started much earlier, but we just didn't, is we're doing a monthly webinar. It was yesterday. I think it's the second Wednesday of the month or third or something like that. And we do it at the lunch hour. It's like from noon to 1, and we have probably 2 years worth of topics. And it's just, a 30-minute presentation and time for the staff to get on and get supervision and consultation around any kind of issue they have going on with a patient that's suicidal. And we've done 2. They've been well attended, and then we put them on the intranet so staff that didn't see it can go back and watch those. So the attendance definitely went way up on the second one, so we were excited about that. So our electronic record, I encourage you, if you have electronic capabilities, whether it's a true EMR or if it's just some kind of electronic functionality you have, it is your friend in terms of doing this kind of work. We placed the Columbia Suicide Severity Rating Scale in our system. We have an education sheet that pops up when you place someone in our pathway that kind of goes over all of the components and tells the patient, we're concerned about them and please call if you can't make appointments and things like that. And we also put the crisis management plan. Those 2, the screening and the education sheet and the crisis management plan, are mandatory. The staff cannot go any further. We put a hard stop in. It was an easy way to get fidelity around those. You just can't go any further till you tend to those. We have our clients display in red who are in the pathway, so anybody that sees that knows that they're high risk. And then anytime a patient goes in or out of the pathway, a high alert email goes out to all the providers that have touched them in the last 90 days, letting them know the patient has either been entered in the pathway or has been removed from the pathway. And it just keeps the staff from having to call each other and go, hey, Karen's in, hey, Karen's out. We put an intake question about weapons in the home in our intake, just so that we could, if we had to go back and look, is this person that has, most of our states are either Midwest or Southern, and, like a lot of your states, people have a lot of weapons in their home. We also ask about internet access and device access, just in case we get to the point our CEO would like to get to where we're doing, a lot more with mobile technology would be wonderful. And then one of the things that our staff dig the most is this last one, and it's the safety functionality when a pathway patient doesn't show. So if Karen's in the suicide pathway and she misses an appointment, and I asked her when I put her in and went over the education sheet to please call, but she doesn't call, the clinician will call and ask them, try to get in touch with them to reschedule. If they reschedule and the person was at, IHOP having pancakes, then they just reschedule, no harm, no foul. If they can't reach them, they put a note in and they hit did not show, which is a code in our system. That sends that patient to our crisis call center's high-risk follow-up team. And they recognize that that's a patient that's in the suicide pathway who didn't show for an appointment, and then they go and seek them out. And we already told them on the front end that this is what we're going to do. Most of the time they're at Target or, or at home, they forgot, but we have had occasion where that was not the case, and we've had to, do some more extreme things. So we screen and assess 12 years and older in every service line at every delivery point. Every time. So if I see a therapist and a case manager, I'm going to get screened which is the first 2 questions of the Columbia scale is what we use. So every time, every appointment, every situation someone is seen, they're asked. There was some provisions around that for programs that are daily, like psychosocial programs. We don't want to ask them every single day. And again, this is embedded in the electronic health record. Addressing means we have really gotten fanatical about, I would just say, in the past year. And so if we can involve family and friends, we try. And we ask that we get a same-day callback to confirm that the means have either been reduced access or restricted access. And we try to get that from family and friends. If absolutely we cannot get it, we try to get it from the patient themselves. And making sure that the staff are documenting that we, have told the patient, look, we're not going to sleep well tonight if you don't call back and confirm that this stuff has been put up. When we made the hard push on this, we found we had to develop a policy on relinquishing weapons, because we had patients showing up and saying, here, Sherry, take my gun, and our staff didn't know what to do, so they would hold this gun, and there's a policy, and I know it's on the SPRC's toolkit website because I sent it in, but you might, we had some things that were coming in that were, pills and knives and things like that. You just want to make sure you have something in place when people want to relinquish that stuff. So the education sheet, again, we want some acknowledgement from the client that we're putting them in the pathway. I get asked sometimes, well, what if they say they don't want to be in the pathway? It's not really a question of their being okay with it. We put them in it. It's for monitoring purposes. And if somebody's really adamant they don't want to go into it, it seems to be a thing that might want to get focused on in the session about why they're adamant about not wanting to be in there. And our crisis management plan looks very similar to probably the millions of others that are out there, just around supports and coping and triggers and things like that. We also felt like patients that were high risk for suicide needed to be seen for therapy. And so we didn't find anything in the literature or come up with some gold nugget that said this is how often we should see them. We sat around a table and kind of said what's realistic. I would love us to be seeing folks every 3 or 4 days, but in reality that's probably not going to happen. So our guideline right now is we would like them to be seen at least for an in-person therapy session at least once a week. And we try to engage and encourage and get them to do that. If it's a patient being seen and they're not in therapy and they're placed in the pathway by, say, a case manager or a medical provider, we talk to them about, our feelings that they really probably need to be seeing a therapist. And we encourage them to do that. If they say, great, I would love to see a therapist, we help them do that. If it's people that say, absolutely not, I'm not going to therapy, we continue to assess and refer and just document that we're continuing to ask people to do that. Somebody's asked why we are screening only screening 12 and above. So we're doing 12 and older. We do, and when I say screen, I mean using the Columbia tool. That's the cutoff. We have used it for maybe a sophisticated or mature 10-year-old, but we're using it for 12 years and over. And if my slide said under, can somebody type and tell me it said under, because I need to change that. It's 12 and over. Monitoring, this is something that it just gave me heartburn a lot of times, is when we ID these folks, we have to keep up with them. And so if they don't show for appointments, we have to know why they're not showing for appointments. They're going into the high-risk follow-up list. We were lucky that we got a couple of federal grants last year via SAMHSA to the Department of Mental Health here to us. And we're going to be able to maybe put our follow-up program into a little bit of overdrive and really, really follow some of these folks for 30 days and some of them for up to a year, and maybe do some in-person. But it's a difficult thing keeping these folks on the grid. We see in Tennessee at any given time about 10,000 patients, and our suicide pathway consistently has anywhere from 200 to 270 patients. So it's a small fraction of the population we see, but it's really hard to keep up with 200 to 270 patients. That's a lot of people, and it takes resources to keep up with them. In terms of quality, one of the biggest issues we had, even within our own system, was who did we count as a client when we were looking at our completion rates. And we had to come to some consistency across our locations about who do we count. Is it somebody we saw a year ago, somebody we saw 2 weeks ago? Our definition, and everybody has to come up with their own, ours is if we have seen someone in the past 90 days or they have a future appointment, we count them. We also have a good number that we seek confirmation through the medical examiner reports. It costs, I think, $20, $25, and we ask for those reports. We know some probably are being called a suicide that weren't, and we know some are probably not being called that should be, but we had some that were sketchy, and we just had to come up with some way to use something to try to get an accurate picture of that. So we look monthly at attempts and completions, and we keep a rolling 12-month count, which I'll show you in a minute. And really, really, I can tell you where we are right now is honing in on fidelity, and we're not going to inject any new components into our system until we feel like 100% we're doing what we say we do. I said, you know, the oven's turned on 400 and we're trying to bake this in the system, but I think the timer is going to go off in an hour and we're maybe at 45 minutes. We got to shore up a little bit of fidelity. When we can and we get dollars like we did through the Blue Cross Blue Shield of Tennessee Foundation, we for a high-risk follow-up study we did, we're trying to put components in there that we can evaluate. And then the 2 new grants we just got definitely have very large evaluation components, but we need funding to look at evaluation outside of follow-up, because most of the funding we've gotten has been around follow-up. So we're continuing to try to make it to the end zone with this. Like I said, I feel like we're at about the 50-yard line. We've got to look at training. We definitely have to look at engagement and treatment, what kind of treatment modalities. We have pulled in the expertise of lived experience, which we did not do the first year, but it's been really great to have some folks that have some lived experience vetting some of the documents and some of the systems we're looking at putting in. We're trying to interface with PCPs. Got a tickle in my throat, I apologize. And looking at further report and EHR development. So we've done all this for about 21 months, and where did it get us? So as I said, we keep a rolling 12-month count because we have about 10,000 people in any given time. So this, over the past 21 months, is the actual number of suicides we had per month. And you see in July of 13, we had as high as 4. And then we've kind of bounced and bounced. And then we had 1, 2, 3, 4, 5, 6, 7, 8 months where we had 0. The next slide shows the rolling 12-month count. So the slide before was the actual number we had in each month. This is the rolling 12-month count. So you can see, like in March of 15, our rolling 12, over the past 12 months, we had had 7, whereas in July of 13, we had been as high as 16. So when you see it in an annual count way, this is our rate. So in 21 months, we have taken our rate from 3.1 per 10,000 down to 1.1 per 10,000. We thought it had gone down to 0.9. We were very excited but we had a coroner's report come in and we had to add a suicide in. So 3.1 to 1.1 over a 2-year, a 21-month span has really had us kind of very excited and happy and really cognizant of how many lives that's probably saved. I mean, we figure if you compare this to the general population, which would be 100,000, we went from about 31 people dying every 12 months that we have to 11, which really seemed for us significant. I think a hard part of that is we're not quite sure which components are doing that. So we're not at a place where we want to cease doing anything or amplify anything because we're just not sure yet which of those are actually having the most impact. So that's the end of the information I have. The goals of this project, Sherry, do you want me to go over this, or do you want to go over the goals that you guys have for kind of pulling in crisis centers and?
I could talk about it if you'd like.
Okay. All right. I'm going to go on mute.
All right. Thank you so much, Becky, for that really thorough presentation. And people can certainly be typing in questions, and we'll have a chance for more questions as soon as I'm done. But I just wanted to talk a little bit more about kind of what the rest of our project with Centerstone is going to be. I think I mentioned at the beginning of the call, we really want to help crisis centers become more familiar with zero suicide and provide assistance to any crisis center who wants to become more zero suicide ready. The initial part of Becky's presentation was really just talking about the movement in general, and up until this point the movement has been really mostly primarily focused on health and behavioral health cares and their care agencies, and there's really only a few crisis centers that we've identified, Centerstone being one of them, that's really taken the zero suicide movement and brought it internally to their crisis center. So part of our supplemental grant does allow for technical assistance. So if there are any centers online here today or any in the network who are really inspired by what they just heard and want to learn more about how they may do this in their own crisis center, we're going to be putting together some tools. We will be putting together, with Centerstone's help, we will be putting together an online microsite tool that will be available, talking about how a center would work to make themselves more zero suicide ready. We'll also, Centerstone is also available for individual technical assistance. So if a center is implementing this in their organization, if they have questions or concerns that they want to bounce off people, that they're going to be available. Becky and her staff are going to be available. Another big piece that we're going to be doing is a pre and post survey on this project. So in the next couple of weeks, I encourage you all to look forward to an email that will come out from John and also be highlighted in our weekly announcements. And we're kind of doing two surveys simultaneously. The first survey is for crisis centers, so for you guys who are here on the phone right now, really asking, how much do you know, especially before you had this webinar, how much do you know about the zero suicide movement? Has your organization implemented this in any way? Because we're really not so sure what's going on at the crisis centers regarding zero suicide. And then is your organization, this is sort of leading into goal 2, is your organization working with any behavioral health care organizations or healthcare organizations in helping them to implement those specific parts of the zero suicide model? So are you providing, and I know centers are doing this, we've already asked a lot about it, but are you providing training? Are you doing risk assessments in a healthcare setting? Are you doing follow-up with an organization? Either under the guise of zero suicide or just because that's a collaboration that you've already undertaken in your organization. At the same time, there's a zero suicide listserv of all of the healthcare organizations who have begun to implement zero suicide within their systems. And we're going to be providing, with Centerstone's help, actually they'll be doing the work on it for us, that we're going to be doing kind of a similar survey with them, but asking them how much do they know about crisis centers, and are they collaborating with crisis centers in their community? Because we really feel like there's a good match. You know, as a behavioral health care organization or a healthcare organization is looking at zero suicide and saying, wow, we need to do all these components. Well, who in our community knows how to do training? Who in our community knows about risk assessment? Who in our community knows about follow-up? That points to crisis centers over and over again. And so our goal really here for the second piece of this is to really help to establish more tools for crisis centers to promote themselves as a resource to key stakeholders as they're implementing zero suicide within their organization. So I really ask you guys, if you're interested in this, or even if you're not, to take a look at that survey and fill it out when we send it out. Of course, when we get the results, we'll be sharing them with the network. Once we have all of these tools finished, so the microsite, the surveys, we will be having a kind of an end of project webinar, so that'll come in the fall, where we introduce the tools that have been created to the network and share those with you all. I guess that's about all that I have to say right now to kind of summarize our project, but I'd love to open it up to any questions if anybody has any.
Thank you, Shari and Becky. And I just I opened up the second poll question for those of you who can take a moment to look at that while you're thinking about any additional questions. It was really helpful to listen to Becky outlining and defining the overall movement of zero suicide, coloring in the picture a bit more, especially walking through Centerstone's journey of implementation thus far. I think that really answers a lot of the questions that people about. And you are welcome to chat in your question or take a brave step and verbalize it on the line.
It looks
Karen.
like there's something that came through, Karen, but I can't see it all.
Yeah, somebody said they would like help and see it as part of their mission, which is great. I guess to reach out, Sherry, if folks have a desire to get some assistance, do they need to reach out to you guys?
I'm open with either way you want to do it, Becky. I guess we should have figured that out ahead of time. But if they have your information here and you're okay with it, if they want to email you directly, that's fine.
Okay.
If you forget how to reach Becky, I mean, anybody at the Lifeline, myself or anybody at the Lifeline can help to make that connection as well.
Well, and somebody here asks, is there a suggested strategy for convincing providers, that this approach is in their best interest, especially saving money? I can tell you, in general, doing all of this that I talked about costs us really very little money. And, I get that question a lot, so and I'm glad to talk, to folks offline about how it really didn't cost a whole lot of money. And I found when our presentation was trying to save people's lives and putting tools in people's hands to try to do that, and then when you unfortunately do have one, that it's no shame and no blame. You don't have to defend it. I was appalled one time when one of our staff said, I have to come up to a meeting and defend my suicide. And I thought, that's horrible that they feel that way. I found once we said we were going to do this, and then the staff saw that we were going to do it, and it wasn't going to go away, and they couldn't wait us out and have it not happen anymore, people kind of all started rowing in the same direction, and I think felt good about, doing that kind of work. It
looks like a lot of people found this information helpful to at least generate some ideas that they can follow through with and implement in an effective way. We will end the webinar in just another moment or so if there aren't any other particular questions, but you can always follow up with, of course, Becky Stoll at Centerstone. You have her information there on the slide. Or, of course, Shari Sinwelski here with the Lifeline. This webinar, once again, has been recorded and will be available via the Lifeline Network Resource Center if other staff would benefit from viewing it and were not able to attend. And thank you to everyone for joining on time. This worked out well with the timing. We really appreciate Becky and all the preparing, and to Shari as well. And it looks like we have to be reached out to or contacting us. You're welcome to reach out to us and let us know how we can reach you if you would like to talk more about this initiative. Thank you for answering our 2 poll questions. This is helpful to us as we prepare each of these webinars. Yes, the slides will be available in addition to the slides are something that are sometimes helpful to just share with staff so they can take a look at what information was touched upon. All of that will be referred to in upcoming Lifeline weekly announcements that are emailed out to you. If you don't receive them and would like to, let one of us know. And then we also post the slides of all presentations on the Network Resource Center.
You know, lots of questions, and also we don't have it all figured out, so if you call me, I might try to pick your brain too as we try to put stuff in place. So just thanks everybody for attending. Really appreciate it.
Mm-hmm. Yes, thank you, Becky. And thank you, Nancy, for sharing your contact email. We will follow up. Thank you to everyone for included.